Cerebral Sinovenous thrombosis refers to clot formation within the dural venous sinuses or deep cerebral veins, obstructing venous outflow from the brain. Reported incidence varies widely, from less than 1 to 12 per 100,000 live births, largely reflecting differences in how aggressively infants are screened and the availability of MRI with venography. The superior sagittal sinus is the most frequently affected site, followed by the transverse sinuses. In many neonates, more than one sinus is involved, which amplifies hemodynamic compromise and increases the risk of parenchymal injury. The pathophysiology centers on impaired venous drainage. Obstruction causes increased venous and capillary pressure, which reduces cerebral perfusion and disrupts blood-brain barrier integrity. The end result is venous congestion, white matter edema, and often hemorrhagic infarction. This venous pattern distinguishes CSVT from arterial ischemic stroke and explains why parenchymal injury is often hemorrhagic rather than purely ischemic. Cerebral Sinovenous thrombosis arises from a combination of maternal, perinatal, and neonatal risk factors. Maternal contributors include preeclampsia, intrauterine infection such as chorioamnionitis, and metabolic disorders including gestational diabetes, all of which create a prothrombotic environment for the fetus. Complications at delivery add further risk. Difficult or traumatic deliveries, meconium aspiration, and the need for vigorous resuscitation or intubation can all produce systemic stress and hypoxia that promote venous stasis and clot formation. In the postnatal period, common precipitants include dehydration, sepsis, and meningitis. Each of these conditions alters hemodynamics and activates inflammatory pathways that impair venous drainage. Extracorporeal life support represents a major risk due to altered coagulation and flow dynamics. Congenital heart disease adds further vulnerability through abnormal circulation and an increased tendency for thrombosis. Clinically, seizures are the most frequent presenting sign. They may be focal or multifocal and often occur in the first days of life. Other presentations include diffuse encephalopathy with lethargy or irritability, apnea spells, and poor feeding. These nonspecific findings make neuroimaging essential whenever venous thrombosis is suspected. Magnetic resonance imaging with MR venography is the gold standard for diagnosing cerebral synovenous thrombosis. MRI defines parenchymal injury and reliably demonstrates hemorrhagic infarction, while MRV provides direct visualization of the venous anatomy and sinus occlusion without the need for contrast. This combination makes MRI and MRV essential whenever CSVT is suspected. Cranial ultrasound plays a supportive role. It can detect intraventricular or thalamic hemorrhage that may occur secondary to impaired venous drainage. However, ultrasound has a high false negative rate for direct detection of sinus thrombosis. When Doppler is used by experienced operators, it may demonstrate altered venous flow, but this requires significant expertise and is not universally reliable. A critical teaching point is that any term infant with unexplained intraventricular hemorrhage should be evaluated for underlying venous thrombosis. This reflects the different pathophysiology compared with preterm IVH, where germinal matrix fragility is the usual cause. Computed tomography has limited utility in neonates. It carries a high false negative rate for sinus involvement, misses subtle parenchymal changes, and exposes infants to ionizing radiation. For these reasons, CT is not preferred in the diagnostic pathway. Management of cerebral synovenous thrombosis begins with supportive measures. Stabilizing hemodynamics, correcting dehydration, and treating sepsis or meningitis are critical first steps. Seizure control is often necessary, since seizures are the most common presenting feature. Anticoagulation may be used in selected infants. Low molecular weight heparin or unfractionated heparin can prevent thrombus propagation and promote recanalization. Indications include extensive thrombosis, evidence of propagation on follow-up imaging, or significant parenchymal injury at risk of worsening. Contraindications include uncontrolled intracranial hemorrhage, where bleeding risk outweighs potential benefit. Prognosis is generally favorable with early diagnosis and treatment. Many infants recover without major deficits, although some develop persistent seizures or subtle cognitive and behavioral difficulties if injury is extensive. early recognition remains the key factor driving outcomes. Stroke in the neonatal period can occur at several distinct time points, each with implications for diagnosis and prognosis. Fetal stroke is recognized before birth, usually as an incidental finding on fetal MRI obtained for other reasons. These events are often linked to maternal or placental pathology, including preeclampsia, diabetes, or clotting disorders. Perinatal stroke encompasses the first 28 days after birth. In the early window, during the first week, infants typically present with acute symptoms such as seizures, apnea, or encephalopathy. In contrast, late perinatal strokes between 7 and 28 days may present more subtly, sometimes without obvious neurologic signs at the time of the event. Presumed perinatal stroke describes infants who appear normal in the newborn period, but later manifest hemiplegia, asymmetric motor development, or other developmental concerns. In these cases, imaging reveals an established injury consistent with a perinatal event that went unrecognized at the time. Recognizing when the stroke occurred is clinically important. Timing determines which investigations are most useful for identifying etiology and strongly influences long-term prognosis. Fetal and presumed perinatal strokes often carry different risk profiles and outcomes compared with acute symptomatic strokes in the early newborn period. Evaluation for inherited or acquired thrombophilia should be targeted rather than routine in neonates. Indications include recurrent thrombotic events, a strong family history of venous or arterial thrombosis, or thrombosis in an unusual location or with unexpected severity. In these settings, a directed workup may uncover a prothrombotic disorder that influences both counseling and management. For isolated neonatal stroke, particularly a single arterial ischemic event, routine thrombophilia testing is not recommended. Data from the International Pediatric Stroke Study demonstrated that only about 19% of affected infants had an identifiable thrombophilic condition, highlighting the limited diagnostic yield in unselected cases. Timing of testing requires careful consideration. Many protein-based assays, including antithrombin, protein C, and protein S, are physiologically low in neonates and can be further suppressed during acute illness. For this reason, confirmatory testing is often deferred until the infant is stable and past the immediate neonatal period. A selective, judicious approach avoids unnecessary investigations while ensuring that infants with clear risk features receive appropriate evaluation for underlying thrombophilia. Thrombophilia testing in neonates can be divided into genetic studies, which may be performed acutely, and protein-based assays, which are best deferred until after the acute illness. Genetic testing is unaffected by the perinatal environment and includes assays for factor V Leiden and the prothrombin G20210A mutation, both of which confer increased thrombotic risk. Testing for MTHFR variants is also available, though its clinical significance is limited, and most guidelines do not recommend it as a routine component of evaluation. Protein-based assays, such as protein C, protein S, and antithrombin 3 levels, are more challenging to interpret in the neonatal period. Physiologic levels of these proteins are low at birth and can be further depressed by acute illness, sepsis, or liver dysfunction. Antiphospholipid antibody testing and measurement of lipoprotein A provide additional information but are also best interpreted when the infant is clinically stable. Other markers occasionally considered include beta-2 glycoprotein antibodies and homocysteine levels. Elevated homocysteine can indicate metabolic or nutritional factors that interact with thrombotic risk, though its predictive value is modest. Overall, testing should be highly selective and interpreted with caution, keeping in mind the unique physiology of the newborn. The clinical value of thrombophilia testing in neonatal stroke is limited, with the International Pediatric Stroke Study showing only about 1 in 5 cases attributable to an identifiable disorder. Testing is reserved for infants with recurrent thrombotic events, strong family history, or unusually severe or atypical presentations. A positive result can influence management by supporting prolonged anticoagulation in selected cases, and it carries implications for genetic counseling of families. A negative result generally does not alter acute care, which remains supportive. Caution is essential when interpreting results. Protein-based assays such as protein C, protein S, and antithrombin are physiologically low in neonates and easily confounded by acute illness. If clinical suspicion remains, repeat testing later in infancy is recommended. This selective approach ensures testing is clinically meaningful while avoiding unnecessary investigations. Outcomes after arterial ischemic stroke in the perinatal period vary, but significant long-term morbidity is common. Roughly half of affected infants develop hemiplegia, particularly with middle cerebral artery territory infarcts. Epilepsy develops in up to 50%, often presenting as infantile spasms or focal seizures later in infancy. Long-term follow-up shows language delays in about half of survivors by school age. Despite these neurologic sequelae, mortality and recurrence risk remain low compared with older pediatric and adult stroke populations. Several prognostic factors help stratify risk. An abnormal electroencephalographic background recorded between 2 and 4 days of life strongly predicts poor motor outcomes. Involvement of the basal ganglia or thalamus increases the likelihood of hemiplegia. The overall size and location of the infarct carry more prognostic weight than the specific vessel involved, since larger or strategically placed lesions disrupt broader functional networks. In contrast, outcomes for cerebral Sinovenous thrombosis are generally favorable when recognized early and treated appropriately. Many infants recover without significant long-term impairment, although seizures and subtle cognitive difficulties can occur. Posthemorrhagic hydrocephalus is defined as ventricular dilatation that develops after intraventricular hemorrhage. The process begins when blood products and clot fragments obstruct the normal circulation of cerebrospinal fluid. In parallel, inflammatory mediators released during clot breakdown damage the arachnoid villi, impairing cerebrospinal fluid absorption. Over time, scarring and adhesions further disrupt both flow and resorption, creating a sustained imbalance. The condition typically evolves over 2 to 4 weeks following the initial hemorrhage. In the early phase, ventricular enlargement is often asymptomatic and may be detected only through routine cranial ultrasound. As the process progresses, clinical signs emerge, starting with a gradual increase in head circumference that outpaces normal growth curves. With more advanced hydrocephalus, classic features develop. The anterior fontanelle becomes full or tense, cranial sutures may separate, and ocular findings such as downward deviation of the eyes, known as sunsetting, appear. These late manifestations signal raised intracranial pressure and the need for urgent intervention. Early recognition of this progression is critical because identifying ventricular dilatation at a subclinical stage allows for timely monitoring and intervention before irreversible injury occurs. Posthemorrhagic ventricular dilatation requires structured monitoring that combines imaging with bedside assessment. Serial cranial ultrasound is the primary tool. Infants with grade 3 or 4 intraventricular hemorrhage should undergo weekly scans to track ventricular size. Quantitative indices, such as the ventricular index and anterior horn width, provide greater reliability than subjective impressions, allowing clinicians to follow progression with precision. Clinical monitoring is equally important. Daily head circumference measurements plotted against standardized growth curves can reveal accelerating trends even before overt signs appear. Examination of the anterior fontanelle for tension, along with cranial suture assessment, offers additional markers of rising intracranial pressure. Neurologic evaluation for changes in tone, consciousness, or ocular position contributes to early detection of decompensation. Magnetic resonance imaging has a complementary role. While not suited for routine surveillance, it provides detailed information for surgical planning and long-term outcome assessment, particularly when there is concern for parenchymal injury or when shunt placement is being considered. Active management of posthemorrhagic ventricular dilatation begins with stabilization while planning for intervention. Ventilation must be carefully optimized to avoid hypercarbia or hypoxia, both of which can increase cerebral blood flow and intracranial pressure. Blood pressure should be kept stable, avoiding large fluctuations that exacerbate ventricular expansion. Fluid balance is another key component. Overhydration can worsen intracranial hypertension, while electrolyte disturbances can compound neurologic instability. Head positioning midline with slight elevation improves venous drainage and reduces intracranial pressure. Seizures, if present, must be treated promptly, since each seizure contributes to secondary metabolic stress and can worsen brain injury. These supportive measures serve as a bridge, maintaining physiologic stability until temporizing or definitive cerebrospinal fluid diversion is undertaken. Management of posthemorrhagic ventricular dilatation has shifted significantly over the past decades. The historical strategy was to watch and wait, initiating intervention only after clinical symptoms of raised intracranial pressure appeared. By that stage, ventricular enlargement was often advanced and neurologic injury already established. Contemporary evidence supports earlier intervention guided by serial cranial ultrasound. Instead of waiting for symptoms, clinicians now rely on ventricular measurements to define thresholds for action. The traditional approach used clinical signs as the trigger, but the modern approach emphasizes initiating treatment when quantitative measurements exceed established cutoffs. Optimal timing is before the ventricular index crosses the 97th percentile plus 4 millimeters. Acting at this stage decreases the risk of progressive white matter injury while still avoiding unnecessary procedures. Several studies demonstrate that earlier treatment based on imaging thresholds reduces the long-term need for permanent shunt placement. This evidence has transformed practice by highlighting the benefit of proactive rather than reactive management, aiming to preserve brain growth and improve neurodevelopmental outcomes. Several temporary strategies exist to manage posthemorrhagic ventricular dilatation while awaiting stability for definitive shunt placement. Ventricular access devices, such as Omnia or Rickham reservoirs, provide a subcutaneous port connected to the lateral ventricle. This allows repeated cerebrospinal fluid aspiration with less handling stress compared to serial lumbar punctures, reducing physiologic instability in fragile preterm infants. The ventriculo-subgaleal shunt is another widely used option. It diverts cerebrospinal fluid into a subgaleal pocket beneath the scalp, where it can be absorbed gradually. This method reduces the need for daily taps and provides a more continuous form of temporary drainage. External ventricular drains offer continuous cerebrospinal fluid diversion, but carry a higher risk of infection and require meticulous management in the intensive care setting. Serial lumbar punctures were historically used to lower ventricular pressure, but are now less favored. The need for frequent procedures, limited efficacy, and associated physiologic stress have led to replacement by more effective and less invasive options. These temporizing approaches bridge the critical period between ventricular dilatation and eventual decision-making regarding permanent shunt placement. The ventriculoperitoneal shunt remains the gold standard for permanent cerebrospinal fluid diversion in infants with posthemorrhagic ventricular dilatation. Placement is generally preferred once the infant reaches approximately 2.5 kilograms and is medically stable. While highly effective, shunts are not without complications. Infection, obstruction, and the need for revision procedures are common, and families should be counseled about the likelihood of multiple interventions over a child's lifetime. Endoscopic third ventriculostomy offers an alternative for selected infants. By creating a bypass pathway for cerebrospinal fluid through the floor of the third ventricle, it achieves outcomes comparable to shunting in some series and avoids the presence of a permanent foreign body. However, technical limitations in very small infants restrict its use, and experience is less extensive than with ventriculoperitoneal shunts. Across approaches, the timing of definitive treatment is critical. Current practice favors intervention based on progressive ventricular enlargement rather than waiting for overt clinical symptoms of raised intracranial pressure. Earlier action is associated with better preservation of white matter and improved neurodevelopmental outcomes compared to the older strategy of delaying until symptoms are obvious. The Drainage, Irrigation, and Fibrinolytic Therapy, or DRIFT, trial was designed to test whether active removal of blood and clot debris could prevent the cascade leading to posthemorrhagic hydrocephalus. The concept was that continuous ventricular drainage, combined with irrigation and fibrinolysis, might clear obstructing material before it triggered scarring and impaired cerebrospinal fluid absorption. The trial demonstrated both risks and potential benefits. Rebleeding occurred in roughly 1/3 of treated infants, highlighting the procedural hazards. Despite this, survivors who received drift had lower rates of severe cognitive disability at 2 years compared with standard care. Follow-up at 10 years confirmed persistence of these cognitive benefits, suggesting durable neurodevelopmental impact. Results overall were mixed. While cognitive outcomes improved, the high risk of rebleeding and the technical demands of the procedure limited broad adoption. Current practice does not include drift as a routine therapy, and larger multi-center studies would be needed before it could be reconsidered. For now, it remains an important research milestone that demonstrated the potential for early intervention to alter long-term neurodevelopmental trajectories in infants with severe intraventricular hemorrhage. Long-term outcomes after posthemorrhagic ventricular dilatation are closely linked to both the severity of the original hemorrhage and the need for permanent shunting. Approximately 18% of infants with grade 3 intraventricular hemorrhage require a ventriculoperitoneal shunt, while rates rise to nearly 30% in those with grade 4 hemorrhage or periventricular hemorrhagic infarction. The requirement for shunting carries a strong association with adverse neurodevelopmental outcomes. Infants who undergo shunt placement are more likely to experience motor and cognitive impairments, although earlier intervention before advanced ventricular enlargement appears to mitigate some of this risk. Among all predictors, the extent of white matter injury remains the most powerful determinant of long-term function, underscoring the importance of early detection and careful monitoring. These infants require structured, ongoing neurodevelopmental follow-up into childhood. Surveillance should assess motor skills, cognition, language, and behavior, as deficits may evolve gradually and become most evident at school age. Regular follow-up ensures timely intervention with therapies and educational support, helping optimize outcomes in this high-risk population. Vitamin K deficiency bleeding is a hemorrhagic disorder of the newborn that occurs because vitamin K-dependent clotting factors are not yet synthesized in sufficient amounts. Historically referred to as hemorrhagic disease of the newborn, this condition underscores the vulnerability of infants in the first weeks of life. The incidence has been dramatically reduced with universal prophylaxis. In settings where vitamin K is given at birth, rates are less than 2 per 100,000. Without prophylaxis, incidence rises sharply to 10 to 20 per 100,000, with much higher risk of catastrophic bleeding. The typical population is previously healthy-term or near-term infants, which distinguishes it from many other neonatal bleeding disorders that occur in the critically ill. Timing varies. Early-onset disease presents within the first day of life, often in infants of mothers receiving anticonvulsants or anticoagulants. Classic disease arises between days 2 and 7, typically in breastfed infants who did not receive prophylaxis. Late-onset disease develops after the first week and can present with life-threatening intracranial hemorrhage. Clinically, the importance of this disorder lies in its preventability. A single intramuscular dose of vitamin K at birth nearly eliminates the risk of severe bleeding, making universal prophylaxis one of the most effective neonatal interventions in modern practice. Vitamin K is an essential cofactor for the gamma carboxylation of clotting factors 2, 7, 9, and 10. It is also required for activation of the natural anticoagulants protein C and protein S. Because vitamin K transfer across the placenta is poor and its concentration in breast milk is low, newborns begin life with minimal reserves. Several features make infants uniquely vulnerable. The neonatal gut is sterile at birth, so there are no commensal bacteria to synthesize vitamin K. Hepatic enzyme systems are immature, limiting efficient recycling of the vitamin. Endogenous stores are already low, and exclusively breastfed infants receive very little vitamin K in their diet. Together, these factors create a physiologic deficiency that places all newborns at risk for impaired coagulation unless prophylaxis is provided. The impact on the coagulation cascade is clear. Vitamin K deficiency prolongs both prothrombin time and activated partial thromboplastin time, while platelet count and fibrinogen levels remain normal. This laboratory pattern reflects failure of the vitamin K-dependent factors within both intrinsic and extrinsic pathways, leading to a serious bleeding tendency despite otherwise intact hemostatic components. Vitamin K deficiency bleeding is classified by age of onset into early, classic, and late forms, each with distinct features and clinical implications. Early VKDB occurs within the first 24 hours of life. It is typically linked to maternal medications that interfere with vitamin K metabolism, including anticonvulsants, warfarin, or certain antibiotics. These infants present with severe bleeding at birth, and importantly, standard neonatal prophylaxis does not prevent this form. Classic VKDB develops between 2 and 7 days of life and remains the most common presentation. Bleeding often occurs from the gastrointestinal tract, the umbilical stump, or circumcision sites. Unlike the early form, classic VKDB is effectively prevented by routine vitamin K administration at birth. Late VKDB arises between 2 weeks and 6 months of age and is the most severe variant, with the highest rate of central nervous system involvement. It occurs almost exclusively in exclusively breastfed infants who did not receive prophylaxis and frequently presents as intracranial hemorrhage. This classification underscores the importance of both prophylaxis and clinical vigilance, since timing of onset provides strong clues to underlying etiology and risk of severe outcomes. Late vitamin K deficiency bleeding is the most dangerous presentation, with intracranial hemorrhage occurring in up to 80% of cases. Neurologic symptoms often develop suddenly and may include irritability, seizures, or altered consciousness. A bulging fontanelle, vomiting, and lethargy are common signs of raised intracranial pressure, making this a true neurologic emergency. The bleeding pattern most often involves subdural hematoma, though intraparenchymal and subarachnoid hemorrhages are also reported. Hemorrhage can be massive and rapidly life-threatening, underscoring the importance of both prophylaxis and rapid recognition. Several risk factors predispose infants to late VKDB. Exclusive breastfeeding without prophylaxis is the most consistent due to the very low vitamin K content of human milk. Underlying malabsorption disorders, such as biliary atresia or cystic fibrosis, further impair vitamin K uptake. Chronic diarrhea and prolonged antibiotic use are additional risk factors that deplete or prevent intestinal vitamin K synthesis. This presentation highlights why universal prophylaxis is essential. Once late VKDB presents with intracranial hemorrhage, morbidity and mortality remain high despite treatment. Vitamin K deficiency bleeding can involve multiple organ systems, with presentations that range from subtle to life-threatening. Gastrointestinal bleeding is the most common and may manifest as hematemesis, melena, or bloody stools. Umbilical cord bleeding is another typical feature in the first week of life. Cutaneous signs are also frequent. Infants may develop ecchymoses or petechiae despite normal platelet counts, reflecting a coagulation defect rather than thrombocytopenia. Oozing from heel sticks or injection sites and expansion of a cephalohematoma may provide early bedside clues. Neurologic bleeding represents the most serious complication, particularly in late VKDB. Intracranial hemorrhage can present with seizures, acute neurologic deterioration, or coma. This carries high morbidity and underscores the need for prophylaxis and rapid recognition. Other bleeding sites include circumcision wounds, nasal bleeding, and oral mucosal bleeding. These presentations may seem minor, but in the absence of intervention, can progress to severe systemic bleeding. The distribution of bleeding across systems illustrates both the breadth of VKDB and the central role of vitamin K in maintaining hemostasis. The diagnostic evaluation of vitamin K deficiency bleeding combines characteristic laboratory findings with careful exclusion of other causes of neonatal bleeding. Laboratory studies typically show a prolonged prothrombin time and international normalized ratio, with values greater than 4 strongly suggesting VKDB. Activated partial thromboplastin time is also prolonged. Platelet count and fibrinogen levels remain normal, helping distinguish this disorder from consumptive processes. Elevated PIVKA2, or protein induced by vitamin K absence, provides a specific biochemical marker of deficiency. The differential diagnosis includes other neonatal coagulopathies. Disseminated intravascular coagulation must be considered, particularly in septic or critically ill infants, but it is usually accompanied by low platelets and hypofibrinogenemia. Hereditary coagulation factor deficiencies, liver disease, and sepsis with secondary coagulopathy can present similarly and require exclusion. Imaging becomes essential when central nervous system involvement is suspected. Computed tomography or magnetic resonance imaging are used to identify intracranial hemorrhage, whereas ultrasound may miss some parenchymal or subarachnoid bleeds. Early recognition through this systematic approach ensures rapid treatment and reduces the risk of irreversible neurologic injury. The American Academy of Pediatrics and the World Health Organization recommend a single intramuscular dose of vitamin K at birth as the standard prophylaxis against vitamin K deficiency bleeding. The dose is 1 milligram for term infants and 0.5 milligrams for preterm infants, given within the first 6 hours of life. This regimen is highly effective, virtually eliminating classic and late VKDB. When intramuscular administration is refused, oral regimens are available but less effective. Multiple doses are required, typically 2 milligrams at birth, followed by 1 milligram at 1 week and another at 1 month. Even with strict adherence, oral prophylaxis does not provide the same long-term protection as the intramuscular route, especially for late VKDB. Parental refusal requires careful counseling and documentation. The discussion should emphasize that the risk is greatest in exclusively breastfed infants and that vitamin K is a simple prophylaxis, not a vaccine. Families who decline intramuscular administration should be offered close follow-up and surveillance for bleeding, since once late VKDB presents, outcomes are often poor despite treatment. Refusal of vitamin K prophylaxis carries serious consequences. Without intramuscular administration, the incidence of late VKDB rises to between 4.4 and 7.2 per 100,000 births, a 50-fold increase in risk compared with infants who receive standard prophylaxis. The case fatality rate is estimated at 10 to 20%, reflecting the high proportion of cases that present with intracranial hemorrhage. High-risk populations include exclusively breastfed infants, those with underlying malabsorption, and infants of mothers on medications that interfere with vitamin K metabolism. Geographic variation is significant. Countries that rely on oral prophylaxis protocols report higher rates, and outbreaks have occurred in communities with clusters of parental refusal. Parental concerns are often rooted in misinformation. Some families conflate vitamin K with vaccines or injection safety issues, while others believe the prophylaxis is unnecessary or prefer a so-called natural birthing process. Concerns about an association with leukemia have been raised historically, but have been refuted by multiple large studies. Other objections stem from a desire to minimize toxins, despite strong evidence of safety and efficacy. For clinicians, refusal is increasingly common. Surveys show that over half of hospitals report a rise in refusal rates in recent years. Addressing these concerns with clear, evidence-based counseling is essential, since the consequences of declining prophylaxis can be catastrophic and entirely preventable. Emergency treatment of vitamin K-deficient bleeding starts with intravenous vitamin K, 1 to 2 milligrams, because it restores the liver's ability to produce clotting factors, though correction takes a few hours. When bleeding is already active, fresh frozen plasma at 10 to 15 milliliters per kilogram is needed to replace those factors immediately. If hemorrhage is life-threatening and unresponsive, factor 7A may be considered, but only in extreme situations due to thrombotic risk. Supportive care runs in parallel, securing the airway, maintaining breathing and circulation, and correcting anemia with transfusion when blood loss is significant. If intracranial hemorrhage is present, measures to control intracranial pressure must begin promptly to prevent secondary injury. Monitoring is essential to guide therapy. Prothrombin time typically improves within 2 to 4 hours, so serial coagulation studies confirm response. A complete blood count helps direct transfusion needs, and repeated neurologic assessments detect evolving brain injury. Finally, if significant intracranial bleeding is identified, early neurosurgical consultation is critical, since timely intervention can strongly influence both survival and long-term outcome. Outcomes in vitamin K deficiency bleeding depend heavily on the site of hemorrhage and the timeliness of recognition. For systemic bleeding such as gastrointestinal or cutaneous sites, prognosis is excellent if treatment is initiated promptly, as vitamin K rapidly corrects the coagulopathy. The most serious outcomes occur when bleeding involves the brain. Mortality in severe intracranial hemorrhage reaches 10 to 20%. Among survivors, 30 to 50% develop long-term neurologic sequelae, including cerebral palsy, seizure disorders, and developmental delays. These outcomes highlight the high stakes of late VKDB in particular. Several prognostic factors determine severity. The extent and location of hemorrhage, the speed of recognition and initiation of treatment, and the degree of mass effect or brain compression all strongly influence survival and long-term function. For infants who survive intracranial hemorrhage, structured long-term follow-up is essential. Ongoing neurodevelopmental monitoring allows early identification of motor, cognitive, or behavioral deficits, ensuring timely intervention and support. Prevention of vitamin K deficiency bleeding requires a broad approach that extends beyond the delivery room. At the healthcare provider level, consistent application of prophylaxis protocols is essential. Clinicians must be prepared to address parental concerns with evidence-based information and to document informed consent discussions thoroughly. From a public health perspective, surveillance data provide critical insights into VKDB incidents. Monitoring allows early identification of clusters or outbreaks, particularly in communities with high refusal rates. Educational campaigns targeting both parents and providers help reinforce the safety and necessity of prophylaxis. Quality improvement initiatives at the hospital level can minimize refusal rates. Strategies include developing standardized protocols, offering alternative regimens for families declining intramuscular injection, and creating follow-up systems for high-risk infants. These efforts ensure that infants who do not receive routine prophylaxis are identified early and closely monitored. Ongoing research remains an important priority. Optimizing dosing regimens, refining delivery methods, and exploring new formulations may improve compliance and effectiveness worldwide. Together, these healthcare, public health, quality, and research measures form a comprehensive prevention strategy designed to eliminate VKDB as a cause of neonatal morbidity and mortality. Prevention of neonatal brain injury requires a coordinated approach across antenatal, perinatal, and postnatal care. For intraventricular hemorrhage, antenatal corticosteroids remain the most effective intervention, promoting vascular and neural maturation. Delayed cord clamping provides a smoother circulatory transition, while gentle handling, stable hemodynamics, and synchronized ventilation reduce the abrupt fluctuations in cerebral blood flow that trigger hemorrhage. For periventricular leukomalacia, prevention focuses on reducing inflammatory and ischemic stressors. Avoiding or promptly treating chorioamnionitis, minimizing episodes of hypoxia or hypotension, and early recognition and treatment of neonatal sepsis are central strategies to protect the vulnerable pre-oligodendrocytes. For perinatal stroke, the goal is to identify and manage risk factors such as congenital heart disease, dehydration, and placental pathology. Maintaining adequate hydration and systemic perfusion lowers thrombotic risk, while prompt treatment of underlying conditions helps prevent progression. Together, these preventive measures highlight that much of the risk is modifiable. By applying consistent strategies across different phases of care, clinicians can significantly reduce the incidence and severity of IVH, PVL, and neonatal stroke. Imaging is central to detecting and monitoring vascular brain injury in the neonatal intensive care setting. For intraventricular hemorrhage, routine cranial ultrasound is recommended between 4 and 7 days of life for infants less than 32 weeks or weighing under 1,500 grams. Follow-up scans at 4 to 6 weeks and again at term equivalent age allow assessment of both resolution and late complications, such as posthemorrhagic hydrocephalus. Detection of periventricular leukomalacia is more challenging. While cranial ultrasound can identify cystic lesions, it often misses diffuse injury. Magnetic resonance imaging provides superior sensitivity, and a term-equivalent age MRI is considered the best method to characterize white matter injury and predict later outcomes. For neonatal stroke, MRI with diffusion-weighted sequences is the most sensitive tool for acute infarction. When venous thrombosis is suspected, magnetic resonance venography is essential to document sinus involvement. Posthemorrhagic ventricular dilatation requires serial cranial ultrasound with quantitative measurements, including the ventricular index and anterior horn width. This approach enables early recognition of progressive enlargement and guides decisions about intervention. Severe intraventricular hemorrhage, particularly grades 3 and 4, carries a 35 to 55% risk of cerebral palsy. Survivors also have a high prevalence of cognitive impairment, and seizure disorders emerge in a subset as cortical scarring becomes epileptogenic. Periventricular leukomalacia is most often linked with spastic diplegia, reflecting injury to periventricular corticospinal tracts for the legs. Beyond motor impairment, children frequently develop executive function deficits, learning difficulties, and visual perceptual challenges that affect school performance. Perinatal arterial stroke produces hemiplegia in approximately half of middle cerebral artery infarcts. Language delays are common, especially with left hemisphere involvement, and epilepsy risk is significantly increased compared with the general pediatric population. Across all of these conditions, outcomes are shaped not only by lesion size and location, but also by the timing and quality of intervention. Early enrollment in developmental programs, physical and occupational therapy, and close neurologic follow-up are critical measures to optimize long-term function and quality of life. Intraventricular hemorrhage remains the signature vascular injury of prematurity, most common in infants born before 32 weeks. Prognosis is guided by grading, and antenatal corticosteroids continue to be the most effective preventive strategy. Periventricular leukomalacia reflects the selective vulnerability of pre-oligodendrocytes between 23 and 32 weeks. The combination of inflammation and hypoxic ischemic injury arrests maturation, leading most classically to spastic diplegia, but also to cognitive and visual deficits. Arterial ischemic stroke occurs most often in the middle cerebral artery territory. Neonatal seizures are the typical presentation, and management is largely supportive, focusing on stabilization and seizure control. Cerebral Sinovenous thrombosis should be suspected in term infants with unexplained intraventricular hemorrhage. Magnetic resonance venography confirms diagnosis, and anticoagulation may be considered in selected cases. Posthemorrhagic ventricular dilatation requires early recognition, since intervention before advanced ventricular enlargement improves outcomes. Multiple temporizing strategies are available before ventriculoperitoneal shunting. Thrombophilia evaluation is not routinely indicated, but should be pursued when there are recurrent thrombotic events, unusual severity, or a strong family history. Across all conditions, prevention strategies are central. Antenatal steroids, rigorous infection control, and meticulous hemodynamic stability consistently reduce the burden of neurologic injury in the NICU.